over to you, Katerina. Thank you.
Okay, great. Thank you. Hi, everyone. Thank you very much for being here today. I'm going to talk to you about the second work package of this project on the benefits and costs of domiciliary care, which is the scoping literature review. And more specifically, I'm going to discuss the conceptual framework that we use to design this literature review. Before starting the main presentation, I need to make the usual disclaimer that this study is funded by the NIHR, and the views expressed here are not necessarily those of the funders. So, one overarching question that this project, and one would argue more generally the policy and academic debate recently are trying to answer, is which types of care provide value for money. Now, within social care, domiciliary care is becoming increasingly important. There is a shift towards receiving care at home, as this is viewed by policymakers and service users as meeting their needs and preferences better and also being more efficient. Therefore, if we want to understand value for money in social care, it is important to understand what is value for money for care provided at home. Now, care provided at home can take different forms. It can include traditional home care packages, which provide support with personal care and daily living, and are provided by home care agencies, third sector organizations, and local authority. But it can also include accommodation that and housing that in which various forms and degrees of support are provided, and services and facilities might be shared. It can include more intensive forms of care, such as with the use of resident carers who provide care around the clock. And it can include different types of employment relationships, as is with in the case of personal assistants, who are carers employed directly by the person in need, and they provide more personalized care at home. So this is what this literature review is trying to answer. So how does the traditional home care package, which I have called here for simplicity as domiciliary care, compare with housing with care and support, living care, and personal assistance, so different types of care provided at home. We are also going to try to answer how does domiciliary care compare with care provided in different settings, such as residential care. The reason for that being that lots of people who receive care at home, particularly those of with higher levels of need, might have to decide between whether they want to receive a more intensive care package at home or move into residential care. So that comparison is also relevant. So overall, understanding the benefits and costs of traditional domiciliary care in comparison to other models of care is important for decision making, particularly under budget constraints, as it can help policymakers understand where to spend money such that benefits are maximized. Now, what we mean by value for money, or otherwise known as cost effectiveness in the economics literature, is an evolving question, and certainly the literature on social care, on cost effectiveness of social care, is still developing. At the very basic level, this includes the comparison of both benefits and costs of alternative courses of action. In our case, that would be alternative configurations of care. But once we go beyond that basic definition, then what exactly we take into account when we do those comparisons is not always very clear. So, for instance, when we look at benefits, one question is what type of benefits should we include in these kinds of comparisons? Quality of life, for instance, is the most commonly used measure when we talk about benefits of social care, but even that can be measured in different ways. So should we look at social care related quality of life or health related quality of life? But how about also other user benefits? Are they also important in value for money considerations? such as capability or quality of care or even health. And another question is whether we need to go beyond the service user and understand whether there's wider benefits from social care, such as, for example, to informal carers or even NHS resources or wider societal considerations. The same applies for costs. Different types of services will use different units of cost measurement. So we need to consider whether we want to focus on utilization of services or focus rather on expenditure. Similarly, which types of costs need to consider in cost effectiveness evaluations? Do we need to just look at care costs, or we also need to include accommodation costs, and in which cases? So these types of consideration, which type of benefits and which costs and how we measurement can actually impact on what it turns out to be, on which services turn out to be cost effective and therefore are important to understand. As these questions are not yet clear, we need to review the literature and take stock of the evidence that is already there. As we are interested in both costs and benefits of domiciliary care and how those compare to the cost and benefits of other types of care, then we will look at those studies that compare the cost and benefits of domiciliary care. So we will focus on cost effectiveness studies. So the aim of that is to identify those studies that do those comparisons, and then try to summarize the evidence. So we will read the studies and try to understand how those studies approach cost effectiveness of domiciliary care. So which types of care and which comparator do they use? How do they measure outcomes and how do they measure costs? Which populations do they use and what kind of methodologies do they employ? So once we have this evidence, then we will critically assess this evidence and try to identify research gaps. For instance, how substantially is this evidence on cost effectiveness? Which models of care do they compare? And are there certain models that are not taken into consideration? Do we think that the measures they use are the suitable ones for this analysis? And are there populations that have not been considered? And are there methods that methodologies that we can improve upon? So as we go along that literature review the journey and trying to understand and assess the evidence, then we would welcome your views as to what you think is important. For example, do you think that the comparators that we present in the that we showed you in this presentation and we will do at the literature review make sense? And are there certain comparisons that you think are more relevant or more important? For example, comparing traditional domiciliary care versus housing with care, or comparing domiciliary care versus residential care. From your point of view, which types of costs are important for economic and policy comparisons of domiciliary care services? And in your view, which benefits of domiciliary care are I'm sorry, that was a question. I didn't pick it up. Let me know. So which benefits of domiciliary care are important for economic and policy comparisons? Do you think that evaluations of domiciliary care services should take a strictly social services perspective, or should have a wider perspective that takes into account other benefits, such as informal carers or other societal costs and benefits? And of course, as always, if there are any other issues that you would like to raise with respect to the literature review strategy, we are here to listen. That's all from me.
Okay, hi. So I'm Hansel, and I'm working together with Florian on this work package, which basically looks at the data resources that we have currently, and looks at the missing gaps in the current resources in regard to this project. So before moving further, I need to put out the usual disclaimer that this project is funded by the NIHR, and the views here are do not necessarily reflect those of our funders. Okay. So before going into the details of the data resources in regard to this project, I thought that it'd be good to give a quick overview of what exactly the analysis is about. So cost effectiveness analysis, essentially what we're trying to do in our final analysis is to link incremental changes in care inputs to outcomes. And outcomes, as we've discussed in the previous session, could be measures of quality of life, whether they be quality of life in the social care related domain or health related domain, or it could be other broader measures of outcomes, such as outcomes in terms of avoidable hospitalizations, or even the quality of life of carers, as has been discussed previously. So the objective essentially is to be able to attribute how changes in input affect outcomes. But of course, both choices in regard to inputs and outcomes are affected by a myriad of other factors. So things such as demographics and socioeconomic characteristics, care needs, so things like the level of impairment, the type of impairment, cognitive and physical impairment, and underlying health conditions would also affect the choice of care and the outcomes from this use of care. And of course, other things such as home and local environments might affect the benefits that you get from care at home, for example, versus care in a residential setting. And beyond that, things such as care provider characteristics. So whether it's a private sector, a provider, would all sort of influence the care outcomes, the outcomes that one would get from care. So given this brief outline, this sort of highlights the different pieces of information that we need to be able to carefully carry out a cost effectiveness analysis. So with this in mind, I'm going to take you very quickly through a few sets of data that we've identified that currently exist, and sort of highlight the gaps in those data sets with regard to this ideal here. And then after that, Florian will talk about our strategy for trying to fill up those gaps. So the first, one of the first data sets that we looked at was the adult social care survey. So this is a nationwide study, and is actually one of the few national level data sets that has quality of life measures and indeed measures of satisfaction with care. But what we found with this data set is that we can't really disentangle domiciliary care from other types of community-based care. And that, as we've discussed, is actually quite important, because we want to be able to analyze different models of care in the community. And also another big gap in this data is a high prevalence of missing information on care spending. So one key part of the puzzle is not available in this data. And in addition, we also have very limited information on individual characteristics. So moving on, during our scoping of the resources, we've also become aware of the adult social care client level data, which is actually it's due to come online in the next few months. It's also going to be national in the sense that it's going to be a mandatory return by local authorities, and it's going to contain information at the client level one key aspect that this potential data set has missing is that it doesn't contain information on outcomes, but it does contain quite quite a sufficient amount of information on care inputs and expenditure. So these two are national level data sets, and in addition to these, we also considered smaller data sets that were collected primarily for research purposes, that we collected in-house through our previous research projects. And one of them that we considered was the data set from the study called the IS, Identifying Impact of Adult Social Care. And so although it does contain pieces of information from each of the key domains that is relevant to us, one drawback is that this data is rather old, it's about 10 years old. And there's still some limits in terms of the information we have on cognitive impairment. And so finally, we also considered data pertaining to residential care and in care homes. And for this, we looked at two data sets from these two studies. And as before with the previous data set, it contains pieces of information that's relevant to us. So there's no gaping gap in each of these domains. But the limitation here is that this is a small sample concentrated in the Southeast. And so it limits our ability to sort of generalize any findings we get from this to national level. So now I'll pass over to Florian, who will talk about our strategy to fill up these gaps in the data.
Thank you, Hansel. So, given the limitations of these data sets, we started to think about other possible ways to get more suitable data, but still trying to avoid a full-scale bespoke primary data collection, which can be quite time-consuming in terms of ethics and governance clearance, as well as design and field work, and therefore could become quite expensive to run. We currently think that a quite good starting point for putting together a data set for cost-effectiveness analysis of care services would be to make use of recent developments with respect to digital social care records, more specifically, care provider digital care records collected through specialized software developed by companies like, for example, Person-Centered Software, Nourish, or Every Life Technologies. We had very helpful discussions so far with PCS and Every Life, and could find out that their software is used by a good range of care providers, from home care agencies and living care agencies to housing with care providers, as well as care homes and nursing homes. And these include tens of thousands of people receiving care. In terms of information on variables covered, our understanding is that these care management records cover quite well care inputs by care providers, both in terms of contact time and care costs or care budgets. It also includes information on individual characteristics of the cared for person and their care needs, so physical and cognitive impairment, activities of daily living that this person persons need help with. And due to efforts of the Data project, which is a project that focuses on developing a minimum data set for care homes, two software providers, PCS and Nourish, are starting to collect in care homes more standardized quality of life measures like ASCOT, EQ5D, and ISCAP, which we think are more suitable for the comparative cost effectiveness analysis. And we're exploring if that could be also extended to other care settings. So these outcome measures would be in addition of the more basic measures of overall satisfaction with care or overall happiness, which we understand are already included in digital care records. Other outcome information already collected is on avoidable health issues such as falls and hip fractures or infections like bed sores and pulmonary infection. A reduction in such health issues could be seen as an additional benefit with positive effects of reducing pressures on the NHS. This data does not, however, include more detailed information on how many hospital bed days care recipients had. Therefore, the Dutch project team has done some groundbreaking work on linking this data to hospital episode statistics using pseudonymized NHS numbers, work from which we are trying to learn from. Further information not included in the data sets is information on the amount of unpaid care and the extra benefits of formal services to unpaid carers quality of life, the choice that persons receiving care and or their families have with respect to the care received, and the housing and local environment. So we would need to collect this information to a bespoke add-on survey. For care provider characteristics, including workforce, we would also need to explore potential data linkage with our skills for care colleagues from the adult social care workforce data set. Next slide, please. Regarding individual employers and their personal assistants, as they are not organized under the hat of a larger care provider, the implementation of digital care records is more challenging, if at all possible. So there are no digital care records for this group. There have been some data collections, for example, by Skills for Care, as well as Think Local Act Personnel and the Local Government Association. But these surveys were rather focused on employer side of the cared for person and recruitment and retention of personal assistants, and with little information on care inputs and none on care outcomes. And therefore, we would need to organize a bespoke survey for this group. Next slide, please. Questions that we would like to discuss with you in the breakout rooms are around the feasibility of our data strategy. What would be the most effective way to collect additional data? Who will be our main partners? Can we organize additional data collection not currently included in digital care records, like, for example, unpaid care, care choice, housing and local environment through software and care providers? Or do we have to plan otherwise? What is the best way to approach individual employers and personal assistants, potentially through Skills for Care and building on their experience and potential network with this group or another organization? And also whether our data strategy sufficiently covers the diversity of people with care needs. Thank you. That is for me. Back to Anne-Marie.